Bismillah wassalatu wassalam ala Rasulillah. Welcome all medical students to this lecture, which is systemic response to injury, and really it is prepared for undergraduate students. As we know that all living organisms, they have specific internal constancy, and they maintain their internal constancy within its specificity by several mechanisms. Those mechanisms collectively called homeostasis. So the homeostasis is body system act to maintain internal constancy. Actually, homeostasis is maintained by coordinated response of all systems to environmental changes, internal, external, to return back to normal physiological status and promote healing. The systemic response to injury is just one of those mechanisms, and it is a mechanism of homeostasis. The ability of the systemic response to injury to return the body back to normal constancy depends on groups of responses. The new researches show that they are not sequential. They don't come one after other. Rather, they overlap each other. Through the sequentially of each response as single detector, or processor, and effector. All of this cycle is regulated by negative feedback. As we see here, we will have detector, processor, and effector. And explaining to what we have just said, that this process inside the response, it comes sequentially, while the group of responses, for example, I have immunological, neurological, and endocrinological responses. So all of them, they overlap each other. But for example, if I take immunological per se, you will see that it has specific detectors which will activate the processor and will go to the effector. So the effector will not be activated except the detector has started to be activated by a stimulus. So inside the system, it is sequential, but different systems are not sequential. The detector, processor, and effector regulated by a negative feedback loop. We have to determine factors that are responsible about variability of responses. These variabilities actually depend on the severity of the injury. So the greater the severity associated with greater response. The second is the duration. So the prolonged duration associated with severe response also. And if the duration is less, you will have less response. The third thing, which is really very important, is patient variability. So the patient variability can be summarized in the following variables. Genetic variability. So from person to person, we will have completely different response. For example, as we are seeing now with the coronavirus, there are some people who they react severely, and others, they don't react the same. At the same time, age of the patient, the younger patient, they will have more severe and perfect response to injury. And at the same time, going back to homeostasis will be for them easier than older patient. Basal health status of the patient is very important. So patient with diabetes will not react to the injury like non-diabetic patient. At the same time, immunocompromised patient, the same way. Patient who has already liver failure will not be like other patients who they don't have liver failure. So the response to injury actually has a specific purpose. The constellation of neuroendocrine changes following injury acts to provide essential substrates for survival, postpone anabolism, optimize host defense. These changes may be helpful in the short term and can be harmful in long term, especially to the severely injured patient who would otherwise not have survived without medical intervention. So, severely injured patient, we cannot apply on them the normal homeostasis. The concept of normal homeostasis is not applicable for severely injured patient. Let's take here an example. If I have patient with bleeding and the bleeding was severe enough and it comes beyond the ability of the vital organs to survive with the extent of the hypoperfusion without artificial support, those patients immediately die. Suppose that this patient receive artificial support. For example, he got IV fluid or blood transfusion, might survive, but the detector baroreceptors signals had already sent to the processor to exert the effect through the effector. We should also keep in mind that such support will decrease the response because dependent on the variability of response, artificial support reduces the severity that would lead to death without this support and reduce the duration of the hypovolemia. So such patient will need further support to prevent the subsequent side effect of the systemic response to injury. After the injury, the general response or physiological response will be immobility or rest, anorexia, and catabolism. And this is maybe clear with us when we got simple viral infection, like influenza or something. You will find yourself next day have immobility, anorexic, you don't want to eat anything. And actually these changes, as we said before, designed to aid survival of moderate injury in the absence of medical intervention. Now we got general idea about the homeostasis and the systemic response to injury. Let's take some details regarding how does it work and how does it happen. As we said, we have detector, processor, and effector. Let's first talk about detector, and then we'll go to immunological system, then we'll as an effector, and also to neuroendocrine system. So first we'll talk about this as a detector, and the detector has a processor, and the effector will talk about them later. So at the area of injury, at the site of injury in the tissues, first stimuli will be the pain for the afferent nerve as detector. And the somatic nerve will go to the hypothalamus to exert its effect by stimulate the sympathetic nervous system and the endocrine system through pituitary gland. At the site of injury also, we will have release of the intracellular organelles, substances of destroyed cell membrane, and release of the damage associated molecular pattern. The DAMPs will be detected by the immunity, like if it is foreign antigen, and we will talk about them later. Remote effect, like indirect effect, it is not at the area or in the tissues itself, like hypovolemia will stimulate the baroreceptor and it will go to the hypothalamus the same way and will activate the sympathetic nervous system and the endocrine system through pituitary. Hypoxia will stimulate the chemoreceptor. Hypercarbia, chemoreceptor along with acidosis. Endotoxin and exotoxin will stimulate the immunity generally. And this is very clear with septic patient. And the septic patient will have the same systemic response to injury like a patient who has very severe trauma. Let us talk here about the local stimulation of the immunity. Inside the cell, there are damage-associated molecular patterns. And we can mention some of them as examples, like high mobility, group box 1, S100 proteins. They are all in all cells cytoplasm. And once there is a destruction of the cellular membrane, they will be released in the tissues and will be detected by immunity cells. We have another example like heat shock proteins. Another example like mitochondrial DNA. So those materials, once they release from the destructed cells, like here, if there is any trauma or necrotic cell, they will be detected by the receptor of the innate immunity and will start to elaborate pro-inflammatory response by releasing cytokines and tumor necrosis factor alpha. Cytokines like interleukin-1, interleukin-2, and other cytokines. Those cytokines will stimulate the other immune cells to come to the area of the injury or to the tissue of the injury. There are several types of receptors. I will not talk about all of them. Just will take an example like toll-like cell receptor and other types of receptors. Once the tumor necrosis factor alpha and interleukin-1 released, they will stimulate the sensory vagus, which will go to the hypothalamus and will stimulate the sympathetic nervous system to release norepinephrine and catecholamines. And then the effect of catecholamines will appear in the patient. At the same time, it will stimulate the pituitary to secrete ACTH, and adrenal gland will secrete glucocorticoids. The stimulation also will have something as a negative feedback to inhibit the release of these materials. And this will be done by two ways, either by glucocorticoids or by parasympathetic motor vagus, which is efferent of the vagus, by releasing of acetylcholine, and acetylcholine will inhibit the tumor necrosis factor alpha and interleukin-1 to be released, and this is complete cycle, and this will bring the patient to the homeostasis. So here we can imagine that we have multiple tissues which have been injured, and it releases a lot of DAMPs. And by the way, the DAMPs will act like PAMPs. This is damage associated molecular patterns, and here is the pathogen associated molecular patterns. This is due to bacteria or virus or any other types of microorganism which infected the body, and the immunity will react with it like a foreign antigen. So DAMP without infection and PAMPs are parts of the microorganism. We can imagine that there are multiple tissues injury, and the amount of the interleukins and tumor necrosis factor alpha is very high. This will cause high magnitude of stimulation of the immunity system, and this will appear on the patient clinically as systemic inflammatory response syndrome, which we will know the definition of the systemic inflammatory response syndrome, or how to diagnose systemic inflammatory response syndrome later. And this is driven initially by pro-inflammatory cytokines, for example, interleukin-1, interleukin-6, interleukin-8, tumor necrosis factor alpha. And this detector, which stimulates this, and this processor and the effector will have negative feedback. First, from the immunity system itself. Second, from the central nervous system, as we talked about it in the previous slide, like acetylcholine will suppress the release of these. So it will be a negative feedback, and also glucocorticoids. At the same time, you will have negative feedback and inhibitors coming from the immunity system itself. Because after these pro-inflammatory released, rapidly you will have increase in the plasma level of the cytokines antagonist and soluble receptors. For example, interleukin-1 receptor antagonist, tumor necrosis factor soluble receptor, and transforming growth factor beta. All of them, they are inhibitor for the immunity as a negative feedback. If this is prolonged, what I mean, the inhibitors, they may take the body into something opposite to the systemic inflammatory response syndrome, and will take it to the counter-inflammatory response syndrome. And here, this is very dangerous, will make the patient susceptible for infection. So as we see here, the inhibitor or negative feedback, the soluble receptors, and at the same time, we mentioned about the role of the acetylcholine and the role of the glucocorticoids. By the way, the sympathetic nervous system has very important role in the inflammatory process, and it increases the demargination of the neutrophils. If we look here, then we will see if we have a high amount of the immunity stimulation, you will have systemic inflammatory response syndrome. And at the same time, this will be inhibited by increasing of the inhibitors from the immunity system. And if this increase too much, it will lead to counter anti-inflammatory response syndrome. In septic patient, we will have different story, that you will have systemic inflammatory response syndrome. At the same time, you have counter anti-inflammatory response syndrome at the same time, because you will have high amount of the interleukins, like tumor necrosis factor alpha, interleukin 1, chemocytokines, interleukin 6, interleukin 12, and etc. And at the same time, you will have a lot of interleukins which are inhibitor. So you will have inhibitors, and at the same time, you have stimulator. And here, the immunological system will not work perfectly, and the patient will have both problems at the same time. Again, at the site of injury, we will have moderator, which released from the cell membrane itself when it is distracted, especially prostaglandins and leukotrienes. These are all pro-inflammatory. And locally, they will have inhibitors like lipoxin and e-resolvins and protectins, d-resolvins, and marcins. All of them are inhibitors or anti-inflammatory, while the prostaglandin and leukotrienes are pro-inflammatory, and they will increase the permeability of the vessels and will increase the number of the neutrophils. Those inhibitors, we call them specialized pro-resolving mediators, and they are released in the tissues of the injury. They will act to downregulate production of the pro-inflammatory cytokines, clear leukocytes from epithelial surface, promote removal inflammatory debris, stimulate tissue regeneration. So these are the servants in the tissues who will clean the area after the battle. This is the main job of the SPM. So just to make it clear, the pro-inflammatory response and anti-inflammatory response, they relate to each other regarding the magnitude. So if we have a high pro-inflammatory response, you will have also on the opposite side, you will have also anti-inflammatory response, the same magnitude. So if the injury is severe, it can cause severe response. by high pro-inflammatory mediators. At the same time, these pro-inflammatory mediators, they will have inhibitors, and those inhibitors will be as greater as the magnitude of the pro-inflammatory response, and these actually will take the patient into counter anti-inflammatory response. So if the anti-inflammatory response is high, it will also make the patient very weak and cannot fight any infection. And the patient will have nosocomial infection. And if the patient gets nosocomial infection, will get back to the pro-inflammatory again, and it will get also anti-inflammatory again. So it will be a cycle, and this will kill the patient at the end. And unfortunately, the SIRS, it will end up with the multi-organ failure. The manifestation of the SIRS are fever, capillary leak because of the capillary leak, and end up with the organ dysfunction. And the organ dysfunction, actually, it happens because of multiple factors, and because of the capillary leak is very high, the interstitial space will be filled with fluid and with the inflammatory process, and this will prevent any interaction between the vascular, interstitial, and the cellular compartments. So that's why we will have multi-organ failure. In addition to other materials, cytokines, interleukins, and other toxic immunological response to the other organs, even if they didn't get injured during the initial injury. After we finish the immunological response, we can now go to important definitions, which is the infection, systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock. Infection, identifiable source of microorganism insult. SIRS, systemic inflammatory response syndrome, is two or more of the following criteria: either hyperthermia, more than 38, hypothermia, less than 36, tachycardia, more than 90 beats per minute, respiratory rate more than 20, or PaCO2 less than 32, which indicate hyperventilation. WBC is more than 12,000 or less than 4,000, or more than 10% of the WBC's band forms. So if we have two of any of these criteria, this is the diagnostic for the SIRS. Sepsis, just identifiable source of microorganism insult, infection, plus systemic inflammatory response syndrome. Severe sepsis is infection and SIRS, which is sepsis, plus organ dysfunction. Septic shock, sepsis, plus cardiovascular instability. The systemic inflammatory response syndrome can also lead to multi-organ failure, even without any source of infection. Neuroendocrine response and metabolism. If we have injury, the afferent nerve will go up, and this is the pain, which we explained in the previous slides, that it will stimulate the hypothalamus and will stimulate the pituitary gland, at the same time the sympathetic nervous system to release the noradrenaline, and the hypothalamus will stimulate the pituitary to release ACTH and growth hormone. At the same time, this is also will be stimulated by hypovolemia, hypoxia, hypercarbia, acidosis, lactic acidosis, due to anaerobic respiration, which happened after low perfusion due to hypovolemia, for example. All of this will stimulate the ACTH and growth hormone together with the sympathetic nervous system. The sympathetic nervous system also will stimulate the adrenal gland to release adrenaline. And at the same time, it will stimulate the pancreas to release glucagon. The ACTH will stimulate the adrenal to release cortisol. So the end result of this is very high blood sugar, but the amount of the sugar which we need now to the vital organs or the organs which has been injured is quite higher than what we have, especially from the liver. At the same time, we need free fatty acid for repair and to be utilized by some cells for energy production, especially immunocytes. So this will end the result with the adipocyte lipolysis, and this will increase free fatty acid in the plasma. The hepatic function here will provide us glucose by the effect of the glucagon, which will degrade the glycogen which is stored in the liver. But unfortunately, the amount of the glycogen in the liver is not quite enough for what we need for the injured tissues, because they need very high amount of glucose. Then we will have skeletal muscle protein degeneration to be utilized for gluconeogenesis. And at the same time, the liver at this time, its role will not be limited only by gluconeogenesis. By the effect of the interleukin-6, the hepatic will postpone now all of its function regarding protein production, like albumin, will be decreased, because the liver now will be affected by the interleukin-6 and other hormones
to increase the production of the acute phase proteins. The acute phase protein has a very important role. It will act as immunoglobulin in the innate immunity, and this will increase also the pro-inflammatory cascade in the immunocytes. At the same time, we have already discussed the interleukin-1, tumor necrosis factor alpha, and interleukin-8 that will be very high in the plasma during this time, 24 to 48 hours of the injury, and this will cause pyrexia. We have very high glucose because directly within 24 hours to 48 hours, we will not have enough insulin, and insulin growth factor and insulin-like growth factor 1 will decrease also. So those will end result with high glucose in the blood. That's why most of the patient in the ICU, they have hyperglycemia. That's why most of the patient in the ICU post-trauma or with septic shock or with sepsis, they will have impaired glucose test because they will have high glucose due to these effects. Within next few days, you will have very high insulin in the plasma. But at the same time, because of the presence of the growth hormone and low amount of the insulin growth factor, low amount of insulin-like growth factor 1, you will have very high resistance for insulin. So the hyperglycemia will continue. At the same time, the area of injury will ask for more glucose. And this will end up also with increase of the hepatic gluconeogenesis, and dependent on the severity of the trauma, the skeletal muscle degradation will increase and we will lose a lot of protein. All of this will take the patient to a status of hypermetabolic status, at the same time loss of lean body mass, which will increase the need of the patient now for external support. Like we have to decrease the muscle work by anesthesia, so the patient will be under anesthesia in the ICU, and at the same time, the patient will be ventilated. Why? Because his muscle or her muscle will not be enough to make good respiration, even if the respiratory system is working nicely. So you need some support to this extent. And as we know now, the patient is immobilized because all of his skeletal muscles is breaking down. The amount of testosterone and T3/4 will decrease in this 24 to 48 hours, and the T3 actually will not be decreased per se, rather than the conversion of the 3T4 to T3, which is the active formula of thyroxine. It will decrease in the peripheral tissue while there is normal thyroid function. So one can divide the metabolic response into two phases. You will have ebb phase and flow phase. So in the ebb phase, during 24 hours, the body wants to maintain the blood volume by catecholamines. And at the same time, the patient will have decrease of the basal metabolic rate, decreased temperature, hypothermic, decreased oxygen consumption, vasoconstriction, and increase cardiac output by increasing heart rate and acute phase protein. And hormones responsible about that are catecholamine, cortisol, and aldosterone. The flow phase can be also subdivided into two phases, catabolic phase and anabolic phase. The catabolic phase will start within 3 days, and to maintain energy and to increase amount of glucose, to provide all of this glucose to the injured tissue. And here you will notice that the patient will have increased basal metabolic rate, increased temperature, increased O2 consumption, and negative nitrogen balance. Negative nitrogen balance means that the patient will excrete more nitrogen than what the patient get from outside as a support. And you can calculate this in the urine. So once there is a catabolism, the protein of the muscle will be destructed to provide amino acid for gluconeogenesis in the liver. And here you will have high insulin, high glucagon, high cortisol, and catecholamines, but there is very high insulin resistance because of these other hormones like adrenaline, noradrenaline, and cortisol. All of them will make insulin resistance. Once everything settles down, after 10 days, even weeks after the trauma, the patient will start the anabolic phase. And the role of this is to replace the lost tissue. And here you will find that the patient will have positive nitrogen balance, that the amount of the nitrogen excreted in the urine is less than what the patient get. And that indication, the destruction of the protein, the degradation of the protein of the muscle now decreased. And here the growth hormone and insulin-like growth factor will increase, and this is their effects on the tissues and on the body in general. Hypermetabolism following injury is mainly caused by acceleration of futile metabolic cycles, is limited in modern practice account of elements of routine critical care. The neuroendocrine response to severe injury or critical illness is biphasic, like acute phase, where everything will be elevated, like actively secreting pituitary and elevated counter-regulatory hormones like cortisol, glucagon, and adrenaline. And the chronic phase, when the patient gets support while he has a lot of complications, especially when we have very high glucose in the blood, you will have a lot of complications. And the patient at this status will be very weak and will get any infection. So if this period of the systemic inflammatory response increase and became very long, this will associate later in the chronic phase with hypothalamic suppression and low serum level of the respecting target organ hormones. Changes contribute to chronic wasting. Glands cannot manufacture needed amount of hormones. The whole body energy and the whole body preserved nutrition will go directly to the central tissues, which are the liver. It is responsible about the gluconeogenesis, immune system, and wound. So most of the energy will go to these places. And from where do we get this energy? From wasting of muscles, adipose tissue, and the skin to provide essential amino acids for the central tissues at this time. The skeletal muscle wasting provides amino acid for protein synthesis in the central organs and tissue. And central organs tissue here is the wound and the liver and the immune system. It is mediated by activation of the ubiquitin proteasome pathway in the muscle and can result in immobility and contribute to hydrostatic pneumonia and death if prolonged and excessive. That's why here, all patient, critically ill patient, they should receive ventilatory support. Because their muscles cannot take over the respiration. Hepatic acute phase protein or response. Hepatic acute phase response. The hepatic acute phase response represents a reprioritization of the body protein metabolism toward the liver and is characterized by positive reactants like increase in the plasma concentration of the C-reactive proteins and negative reactant like plasma albumin will decrease. Most of our glycogen is in the muscle. Why we don't use it during trauma? Here. The answer is the glycogen which is inside the muscle, it needs glucose 6-phosphatase. And the glucose phosphate is the biochemical form of the glycogen. So you need this enzyme, the glucose 6-phosphatase, to degrade this glycogen and it become glucose. But unfortunately, the myocyte doesn't have receptor for this enzyme. So we cannot use the glycogen which is stored already in the muscle. So first, the liver will provide the amount of the glucose which is stored inside it as a form of glycogen, and actually the amount of this glycogen will be enough for first 24 to 48 hours maximum. And later on, the protein wasting from the muscle will start to provide essential amino acids, especially alanine and glutamine, to start the gluconeogenesis in the liver. So the problem is that once we waste muscles, it means that we are wasting. During the muscle wasting, as we said before, we will have negative nitrogen balance. And we explain this by the amount of the protein which the patient taken is less than what the patient lost or waste. And we can calculate it by the amount of the nitrogen in the urine. How can we calculate this? The loss of 1 gram of nitrogen in urine is equivalent to breakdown of 6.25 gram of protein, which is equivalent to loss of 36 of wet weight lean tissue. And this will make the patient at this status very weak, vulnerable for infection, and will have a lot of complications. Post-severe injury, you will have weight gain in the first 3 days. And this is the net effect of multiple factors. First is a resuscitation fluid, which is given to the patient. Second, effect of the endocrine system as a response to injury. The endocrine system will lead to retention of fluids. And how is that? By aldosterone, cortisol, and also to some extent adrenaline. After 3 days, the patient will have sudden decrease of the weight. And this is due to the start of the catabolic status. And at this time, the patient will be at risk of having multi-organ failure and sepsis. This time, regarding the immunity, at this time, the immunity will be the lowest because of the counter-inflammatory response. And most of death of the severely injured patient will happen during 8 to 10 days after the trauma. So once you have a traumatized patient, you have to avoid any stress or further stress to stop the systemic response to some extent and to decrease the severity of the first systemic response, to decrease also the severity of the counter-regulation of this response. And this can be avoided by decrease any hemorrhage or continuing hemorrhage, normalize the patient temperature, avoid hypothermia and hyperthermia, decrease tissue edema, decrease the pain, and increase the perfusion of the tissue. And we have to remember here one important factor, that once the patient have reperfusion, maybe the toxins which are in the area of the injury and the area which had been hypoperfused, you will have a lot of toxin like lactic acid due to anaerobic respiration, and at the same time you have also free radicals and nitric oxide. And once you reperfuse this patient, the blood will take all of these toxins and will bring it to the whole body, and whole body will be affected. Let us take here an example like nitric oxide will be very toxic to the myocardium. Avoid also starvation and avoid immobility as much as you can, especially in post-op patients. They are also after trauma. So is the surgery stress? Yes, it is very important to mention that it is like trauma, but it is mild to moderate. That's why the body will not show all of these catabolic status. And we have to decrease the response to surgery by a lot of ways. Some of them, we have to use minimal access technique. This will decrease the systemic response. Blockade of the afferent nerve by epidural analgesia or even local anesthesia for the tissues. If you are going to do surgery, even if the patient under general anesthesia, as long as we have pain, the detector will detect the tissue injury, which will be done by the surgery and will transmit the signals to the hypothalamus. So better to have local anesthesia at the area of the wound, of the surgical wound, before the incision. Try not to keep the patient fasting pre-op for a long time, and mobilize your patient as soon as possible. At the end of this talk, you're probably able to define the hemostasis, determine factors that are responsible about variability of response, demonstrate understanding of purpose of response to injury, list the factors responsible for systemic response, discuss each type of response to injury, neuroendocrine and immunologic response, differentiate between infection, systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock. And good luck.